Introduce you to our wonderful guest speakers. So the Future of Nursing 2020-2030 report in the Access to Care chapter didn't only include access to APRN care, removing barriers to APRN care in public policy. It also talked about the importance of lifting those barriers at the institutional level. It also has many recommendations regarding registered nurses' scope of practice. Today's program will feature mostly APRN, but also some mention of RN, I believe. And we have two wonderful guest speakers. So first, we will have Mr. Marcus Henderson. Marcus is a PhD student at Johns Hopkins University, and he was a committee member on the Future of Nursing 2020-2030 report. And it also turns out he is on the American Nurses Association Board of Directors. And then following Marcus is another wonderful friend and colleague, and that is Dr. Toby Bressler. And Dr. Bressler is the Senior Director of Nursing for Oncology and Clinical Quality from Mount Sinai Health System in New York City. So, and let me just double check. Okay, everybody is muted except for the two speakers. So at this point, I'm going to ask Marcus to come on and share with us his knowledge about what the committee notes about lifting institutional barriers for care.
Hi, and thank you so much, Dr. Quinn and the Campaign for Action for hosting this webinar. I am excited to be here at the Access to Care Learning Collaborative, and I'm also delighted to be here with my colleague, Dr. Toby Bressler, to speak with you about this important topic. And as Dr. Quinn noted, I'll be talking just high level about some of the areas that the report covers related to scope of practice barriers. And then I also do have some examples to focus in specifically on registered nurses. And as we all know, the Future of Nursing report builds on progress that nurses have made in the past decade. And you may recall that the first report called specific attention to expanding scope of practice for nurse practitioners and APRNs. And it was, in fact, the first report in 2010's one of their primary recommendations. And this report, as Dr. Quinn noted, extends beyond expanding scope of practice for APRNs, but really calls attention to the need to eliminate practice barriers for all nurses as we collectively seek to create a culture of health, reduce health disparities, and advance health equity. So the committee's vision, many of you probably have heard this a dozen times, but I don't ever think it hurts to restate it, that it really is the achievement of health equity in the United States built on strengthened nursing capacity and expertise. And by leveraging these attributes, and in this case, that's nurses' capacity and expertise to assess, diagnose, treat, and manage patients, nurses will help to create and contribute comprehensively to equitable public health, social service, and healthcare systems that are designed to work for everyone and eliminate disparities. And for our country to achieve health equity for all, the systems that educate, pay, and employ nurses need to permanently remove barriers and allow nurses to provide the care that they are educated and trained to deliver. Therefore, policymakers, whether that's in institutions or governments, need to permanently lift artificial regulatory and practice barriers that keep nurses, RNs, and APRNs from practicing to the top of their education and training, and that restrict people's access to high-quality care. Nurses at all levels and in all settings have the education, skills, experience, and training to fill critical care gaps and address health disparities, only if they are given the autonomy and institutional support to do so. In the report, we discuss two types of barriers that nurses face: those relating to scope of practice, which can be lifted through policy changes, and institutional ones, and institutional barriers as the other that affect where nurses work, learn, and train. Nurses have substantial and often untapped expertise to help individuals and communities access high-quality care, particularly in providing care for individuals in underserved rural and urban areas. Improved telehealth technology and reformed payment systems have the potential to increase access, allowing patients to obtain care in their homes and in their communities. However, the ability of nurses to practice fully in these settings and others is limited by state and federal laws and institutional policies that prohibit nurses from working to their fullest extent. So what does it mean to expand scope of practice for nurses? And of course, as many of you know, it means to remove barriers that prevent nurses from practicing at the top of their education and training. But what does it really mean? It means that everyone, no matter who they are and where they live, have access to high quality, affordable health care and opportunities so that they can be healthy and well. And in the United States, more than 80 million people, roughly 1/4 of the country, live in an area with a shortage of healthcare professionals. And current physician shortages will continue to increase over the next decade, particularly in the areas of primary care, mental health, geriatrics, and in rural areas. We're all very familiar with this graphical depiction of state scope of practice for nurse practitioners, and I'm sure Dr. Quinn is going to pick out that I need to update my slide because Delaware's color needs to change here. So I'll note that first. But we know that eliminating restrictions on the scope of practice of APRNs so they can practice to their fullest extent will increase the types and amount of high quality healthcare services that can be provided to those with complex health and social needs, and improve both access to care and, as I mentioned, in rural and underserved communities, but most importantly, advance health equity. The evidence has shown that expanded scope of practice improves quality of care, and that scope of practice restrictions in fact limit competition and contribute to higher healthcare costs. And during the pandemic, 8 states emergently expanded scope of practice for nurse practitioners so that more people could access care. And again, considering the severe physician shortage our country is experiencing, expanding scope, but really eliminating practice barriers for all nurses has the potential to significantly improve access to care. Until all nurses and APRNs are permitted to practice to their fullest extent, significant and preventable gaps in access to care will continue. And nurses at all levels and settings face institutional barriers to fully leveraging their skills and abilities to advance health equity. These range from restrictions on providing telehealth services to workplace policies that prevent them from providing optimal care, and to barriers to nurses' career advancement in health. And all of these institutional barriers, by way of policies and procedures, hinder nurses from being able to fully utilize their education and training. An often cited example is by capitalizing on registered nurses in the primary care setting. In 2016, the Macy Foundation published a report on transforming primary care. We know that registered nurses can perform chronic disease management, care coordination, and other preventative services, but their role still remains largely focused on patient triage. This limits the nurse's ability to effectively and efficiently manage and deliver care, and similar in other settings, nurses are often underutilized. A study by Flinter and colleagues in 2017 looked at high-performing primary care clinics, and in this study, they described the implementation of independent RN visits and care management through the use of standing orders and standardized practice protocols or team-based protocols. These mechanisms allowed registered nurses to initiate prenatal visits, handle medication titration in chronic disease management, such as titrating insulin or increasing antihypertensive doses. Registered nurses were able to independently conduct preventative visits, monitor minor acute illnesses, and provide significant disease management and care coordination to the panels of patients that they were assigned. The study goes on to describe how teams of nurses provided assessment, management, and treatment. This included prescribing medications to patients presenting with well-defined symptoms and conditions. Most commonly in these instances were upper respiratory and urinary tract infections. Some other practices established protocols where nurses managed latent TB infections, tested and treated for sexually transmitted infections, were the primary leads on asthma education, support, and testing. So standing orders and team-based protocols have been successfully used to allow nurses to order routine immunization, screening, lab tests, medication refills, working with very defined chronic diseases, but also among specific patient populations like children and pregnant women. So nurses, well, in this case, standing orders and team-based protocol leverages the education and training of all members of the care team and maximizes team operations, promotes quality of care, and improves outcomes. But as I mentioned, their use remains variable across settings and locations. And instead of capitalizing on nurses' roles and abilities, patients continue to experience care delivery systems that are inefficient. Again, these examples are specific to primary care, but there are certainly circumstances across settings where practice barriers are preventing nurses from effectively doing their jobs. Another example, I was speaking with a colleague who was doing some work in Texas, and at this particular acute care facility, registered nurses are not allowed to administer suicide risk screenings like the commonly used Columbia rating scale. Registered nurses have to place a consult and wait for an ordering provider, such as a psychiatrist or psychologist, to come and assess the patient. So this leads to significant delays in appropriate intervention and safety planning for patients at risk for suicide. Again, just another small example of where we're limiting nurses to effectively do their jobs in their jobs delivering care to patients. So what are the potential consequences if these practice barriers are left unaddressed? Well, the cost will be felt by patients. Patients will experience unnecessary and avoidable delays in care, increased wait times, and as a result, experience reduced or poorer outcomes. The quality of care changes when nurses are not able to practice to their fullest extent, and care delivery systems, as I mentioned, become ineffective and inefficient. So the Future of Nursing report recommends that all organizations, including state and federal entities and employee organizations, should enable nurses to practice to their fullest extent by removing barriers that prevent them from more fully addressing social needs, social determinants of health, and improving healthcare access, quality, and value. These barriers include regulatory and public and private payment limitations, restrictive policies and practices, and other legal, professional, and commercial impediments. And I would also say that nursing shared governance models stand to be an important vehicle to drive nursing practice change at the institutional level when we're talking about RN level work. And the following specific actions the report prioritized are that by 2022, all changes to institutional policies and state and federal laws adopted in response to the COVID-19 pandemic, as we have seen with expanding scope of practice, telehealth eligibility, certain provisions for insurance coverage and payment parity provided by APRNs and RNs should be made permanent. And that federal authority, for example, by the Veterans Administration or the Center for Medicare and Medicare Services, should be used wherever possible to supersede restrictive state laws in these similar areas in order to decrease access to care and burden nursing practice. And that the Healthcare Regulator Collaborative should work to address interstate compacts and the adoption of model legislation to improve access, standardize care quality, and build interprofessional collaboration and interstate cooperation. And the evidence shows that these actions, among many others, will help expand and improve access to care for people and communities across the United States, particularly those who have experienced limited access to care and public health services. And that's all for me.
Marcus, thank you so much. That was very informative. And at some point, it would be good to have a conversation about the concept, the term expanding scope of practice. I see that Dr. Andrea Broussard is on our call today, and Andrea is a former colleague, and she taught me that it's not about expanding scope of practice. It's about expanding access, but that scope of practice is determined at the educational level, not in the regulatory level. So just, yeah. Okay, so Dr. Toby Bressler, if Oh, Andrea is seconding that emotion in the chat. Thank you, Andrea. Toby, I'm so delighted to have you. And I also want to tell folks, if you're ever at a conference and Toby and or Marcus happen to be there, they may or may not be ready to go salsa dancing with you in the middle of the night. Just want to put it out there. So that's it. The floor is yours, Toby. Take it away, Dr. Bressler.
Thank you. Thank you, Dr. Quinn, for having me today, and thank you to the Campaign for Action. So I'm going to switch gears a little bit here right now and talk to you about our experience in New York City, and in terms of reframing scope of practice and practice limitations that we kind of used COVID-19 as the tipping point to change some things in our institution. So March 2020, New York City was the epicenter of the pandemic. And in oncology, we found that our patients had a limited surveillance and follow-up access to care. So for example, there was diluted patient care delivery, surgeries were canceled, mammograms were canceled, imaging studies, colonoscopies, endoscopies, everything was on a very limited operation and operating schedule. And we took a pause with all the craziness that was happening, and we recognized that nurses are boundary spanners. And we used this opportunity, this point in time that we had, to push the agenda forward of really mobilizing our advanced practice nurses and our registered nurses to take on their full capacity and abilities. So with that being said, I will share with you, we were very respectful of traditions, but sometimes long-held beliefs get in the way of taking good care of people. So the first step that we did was acknowledge the power structure. And we used existing relationships on behalf of the team. So let me share with you some examples of what we did. Formerly, our practice in oversight of our infusion suites where we deliver chemotherapy and immunotherapy was only physicians were able to provide that oversight. During COVID, we had a limited physician coverage, and we were able to quickly mobilize our NPs to move into that role. Our NPs currently are now listed as the covering provider in all of our infusion suites across our health system. For CMS, the requirement states to have a provider on site. Again, historically, this was physicians, and now it is NP-led with NPs overseeing chemotherapy administration, symptom management, and infusion reactions. So more about the data of what we found a little later. Our NP services are often provided, it's called incident to. So it's an incident to physician services. We're in a practice and billing arrangement that allows for billing and NP care delivery under a physician's name. So CMS defines care as incidental if the care is provided under strict supervision criteria, including the physician being on site and the patient receiving care in accordance with the treatment plan. This incident due designation really limits NP autonomy, and the payment for incident to services provided by NPs is at a limited percentage of the physician rate. So that leads some NPs to report pressure from physicians and from health systems against seeking direct payment as designated a primary care provider, meaning the person that the patient comes to see is the NP, because it results in a little bit of a lower payment to the practice. I'm going to share with you our experience of our NPs all being billable providers. This process was new for us. So adding NPs to insurance PARs, creating templates for them to see patients independently was a prime example of using COVID when everything from IT to administrative paperwork was accelerated. So we were able to take advantage of that. It was a heavy lift, but we made it. And now I can proudly tell you our NPs are visible in the electronic medical record, seeing a full panel of patients. So what does that mean? For our busy breast surgeons, it means the flexibility to schedule more surgical patients. For our medical oncologist, it means more time working on new chemo protocols, all the while patients are continuing to receive high quality care and their ability to increase our access to bring patients in. So as a result of all those things, our patients have had a decreased wait time to see a provider. So before implementation in 2019, before implementing our NP-led services, a patient may have had a 4 to 6 week wait time for an appointment with a physician. Now we accommodate patients within a week's time. All of our high-risk patients, all of our high-risk survivorship clinics are fully run by our NPs. That means anybody who is more than 365 days out of treatment are now seen as a regular follow-up visit by our advanced practice nurses. As we began this journey, we realized and we revised certain policies, and we recognized internally that words matter. So we changed the semantics that were embedded in our institutional policies from supervising physician to collaborating physician. As we updated our policies, we systematically, one policy at a time, revised the use of physician to provider to be inclusive of all of our NPs. And of course, I would be remiss if I wouldn't say we are eliminating, deleting the use of the word physician extenders. Currently, all of our APNs have a DEA and an NPI number to allow them to practice at full scope, prescribing controlled substances to our oncology patients. They are so brittle and vulnerable, and they need at a moment's notice controlled substances that may not be able to be prescribed by anyone else other than our oncologist. Historically, only the physicians were reimbursed, thereby perpetuating inequities, limiting the access of our NPs to have full prescribing privileges. Now, with this new change, we are reimbursing all of our NPs for their DEA and NPI numbers, and we have seen a significant decrease in turnaround time for medication refills. Furthermore, we created an ongoing professional practice evaluation called an OPPE, and it incorporates nursing care indicators and nursing-specific language that is used to evaluate NP performance. An OPPE now is currently signed off by the NP and the nurse leader. Historically, the long-standing practice was that this was completed and signed off by the MD and didn't have relevance to the NP and didn't have meaning to the nurse practitioner in practice. What was an extra, I guess, icing on the cake, if you will, is we moved all of our advanced practice nurses under the hierarchy of a nurse leader. This was a huge shift. Historically, all the NPs reported on paper to an MD in the table of organization. Currently, we now have clinical program managers who are all advanced practice nurses at each of our sites who oversee the NPs and lead an advanced nursing practice. Nurses must lead nursing practice. So I just want to finish off with saying we're all in the same boat, and hopefully we're rowing in the same direction. Some of our recommendations are to waive and relax scope of practice for nurses in advanced practice from the institutional level. We aren't doing ourselves or our patients any favor with restrictions and barriers to practice. We need to have more data-driven conversations. So now at boardrooms, I'm able to use our data to drive conversations to implement this in other service lines. For example, the number of patients accommodated that we saw after 2020, we saw a 23% increase in overall clinic volume, with a 36% increase of being able to accommodate all of our patients within 1 week of a referral. And this was all happening during the height of the pandemic. During the height of the pandemic, we saw approximately 1,600 patients a month. We were keeping with the same pre-pandemic volume. The physicians were seeing all new diagnosis, all new cancer diagnosis patients, and the NPs were seeing all follow-ups and symptom management patients. I would advise to anyone who's starting this journey is to start small. Start looking at your institutional barriers. Look at the semantics of words matter. Use the words advanced practice providers. Start slow and amend one institutional policy at a time. And it's less about me and more about we. Just in order to maintain this momentum, we learned that we need to seize the moment. We need to have forward thinking in order to innovate, truly create innovation at the point of care in order to best deliver care to our patients and their families. I will share with you that the preconceived notions of the artificial boundaries are much more permeable than we originally thought. And we are very agile when we're pushed to open to change. Let me share with you just 3 stories from our patients, and these are their words, not mine. We send out surveys to all of our patients using a Q review score, and 3 of our patients wrote to us, "This entire experience from the moment I checked in as a new patient from reception continued on with the nursing staff, and Moses, the nurse practitioner, was amazing. This was probably one of the more professional offices I've been to, and I really appreciate it." Another comment, "I commend the NP for her unhurried, personable manner, as well as being knowledgeable and sharing her expertise in very down-to-earth terms. It was so helpful." And last, "I was extremely impressed by the level of expediency and the staff and clinicians. In fact, there was 0 wait time. Just as I was sitting in the wait room chair, my name was called to take vitals and head back to the office. The nurse practitioner, the nurse, and then to check out. I was so pleased and felt so assured, and I left with feeling great confidence that everything will be okay." So these words really have the most meaning because they're from our patients and they're their words. So that's all I have to share with you about my experience with our team here at Mount Sinai in the health system in New York, and I'm open and welcome to answer any questions you may have.
Thank you so much, Dr. Bressler. Such powerful words, right? Really great. Thank you. So, Mr. Henderson, there is a question in the chat for you, and it's from Dr. Sandra Cotton, who is, if I remember correctly, now in West Virginia and was in Arkansas before that. And she's
always West Virginia.
Okay, take it away, Sandra.
Oh, Marcus, I just was wondering if you're talking about the RNs, like running lipid clinics or running whatever, chronic disease management clinics, if the inability to do that was tied to billing or revenue generation or the loss thereof.
In my readings and in my preparation for when we were doing the report work, we really didn't get into a lot of that because there's not a lot of, at least at the time, there wasn't a lot of evidence to kind of, for a National Academy report, it's all about the evidence. It can't be in the gray literature or things they're reporting. So we had a hard time finding those things. But I would sense that's probably true. And I think as we begin to navigate all these conversations about value, how do we measure, quantify, and value nursing services, I think that will probably change. But that's inevitable. It's always tied to payment somehow. And that's probably a whole nother access to learning collaborative just about payment.
Well, and you know, it's really striking the underutilization of RNs, let alone of APRNs. And so when you talk about the primary care management, it's like, wow, like, come on.
No brainer.
People. Okay, thank you. It was a wonderful presentation. Yeah. Thank you. And thank you, Dr. Bressler, as well. Both wonderful.
Thank you.
It's still just so variable. I saw one comment in the chat about the public health departments in North Carolina that have some standing orders. And I think that's a great example of nurses also not reading their state practice acts or understanding the extent of which that their state law allows them to practice in certain ways. So I think Dr. Bressler had great examples of, you could be in a full practice state, you could be in a reduced scope state, but if your institution doesn't review their policies, doesn't actually change the language and things like that, we're not going to make these smaller changes at the institutional level.
That's what I was going to ask you, Clea. I'll be with you in just a minute. I see your hand. Thank you. That's what I was going to ask, because what Jean Ann Davison is pointing out is that there's a public policy that will allow this, but then it's still the institution that needs to update its policies to reflect the public policy, correct?
Yes.
Yeah.
And it's going uphill against history and tradition and institutional gatekeeping to kind of push that envelope forward, and in a friendly and lovely way, but it's really pushing the envelope and taking the moments in time that you have available to you and seizing that moment.
Great, thank you. I'm opening up. Oh, I can't. Clea, can you unmute your line? I'm trying to unmute it and I can't for some reason. So Clea, if you go up to the top of your screen, do you see where it says leave? And then just to the left of that, it says share. And then to the left of that, it says mic, M-I-C. Well, let me, if I could, I might be able to do it this way. Oh. We can hear you, Clea. I can't, let me see. That's so strange. I wonder why I can't unmute Clea. Clea, do you know how to use the chat? No. Do you want to email me? You know how to email me. If you can email me right now. We can't hear you.
If you make one of us co-host, either Marcus or I can unmute.
Really? Because I'm a host and I can't unmute her. And I think that's only in Zoom, by the way. In Teams, you'd have to have an ARP account, and I don't have any of my ARP colleagues on. Andrea, why are you not here anymore? So Clea, if you go to your email and email me right now, I will ask your question. Andrea. Okay, so okay, she's leaving. Okay, so then Linda Thurby Hay from Virginia is saying, I want to share another APRN group that is pushing boundaries. In Virginia, I've developed an across continuum program for diabetes care, wherein CNSs are employed via a medical group. Linda, do you want to unmute your line and share what you're doing?
Can you hear me?
Yes.
Yes.
So one of the issues that we have in the Commonwealth of Virginia is we have a very strong medical society that really has dictated what advanced practice can do. Our nurse practitioner colleagues have engaged with them for many years trying to push that boundary. I'm a clinical nurse specialist, and oftentimes when I hear discussions about APRN practice, the discussion ends up being about NP practice, and the rest of us in the APRN world feel like our practice role needs to be included in these discussions. And so what I have done in Virginia is, when I got to move to a new health system, I really wanted to look at what clinical nurse specialists were doing. And because, we're educated to be specialists in a particular field of practice and impact care on 3 different levels, I wanted to utilize clinical nurse specialists that were already employed in the system, pull them out of their professional development departments, which is where we usually tuck these folks, and get them out there where their true expertise in clinical practice can be utilized. And so in the system that I'm in right now, I have 5 clinical nurse specialists that are devoted to diabetes management on the inpatient side. We are spread across 3.5 hospitals in the Richmond, Virginia market. What we did is we employed them through a medical group, and that way they are identified as providers and they can bill for their services. It's not incident to anybody. We do have to have a collaborating physician within the Commonwealth of Virginia, and Virginia just passed last year prescriptive authority for CNSs. And so now we're working through that institutional piece where you have to get either medical bylaws or an APRN policy to permit prescriptive authority by the clinical nurse specialists. We're still in process of doing that. But right now, for the past 2 years, we have been making recommendations, billing for our services directly, and we are becoming known as the go-to folks for inpatient diabetes management. So I wanted to bring the clinical nurse specialist role to the forefront because, again, what I often hear in these discussions of APRN practice is a focus or all examples related to NP practice, when indeed we have CRNAs that are fighting for the same issues, nurse midwives that are fighting for the same issues, and CNSs are also fighting for those same issues.
Yeah, excellent point, Linda. And actually, to me, from a patient and family caregiver perspective, especially somebody who's an advocate for older adult care, clinical nurse specialists have a very, very special place in my heart. And I'm a big champion of you and your work. So thank you. Toby, would you, as a clinical director in a care environment, thoughts about clinical nurse specialists?
So I will share with you that when I started graduate school, I started off as a clinical nurse specialist. So absolutely agree that clinical nurse specialists are the glue that hold an institution together. I will also say that it's not a very well understood role. So from institution global perspective, one needs to clearly articulate the need for a clinical nurse specialist and what they can do. And it is complicated. I mean, we in the Sinai system, we have 9 hospitals, 13 ambulatory sites, and a medical board that takes quite some time to move things through. So in order to, change that type of practice, one needs to be diligent and persistent. So I agree. I think from diabetes care to skin and everything in between, the CNS's role is one that's extremely important.
One thing I will add to the conversation is, as the lead CNS in this program for diabetes health, the other piece of this is that we have initiated an ambulatory program where we have embedded RNs and RDs within primary care practices so that they can directly impact that population. So, if you read a little bit of Linda Seminario's work out of the University of Pittsburgh, she planted diabetes educators in primary care through a grant and really demonstrated that when providers actually are around diabetes educators, they understand how they're contributing to the care of the patient, begin to value educating patients, which we know is a real issue in most chronic disease management, and they utilize that service a lot more consistently. Our people are actually in those practices. They're developing relationships with those providers. They're working to lower patients' A1Cs and increase their confidence in self-care. And that's the system change that, as the lead CNS, I'm working on. It's not just about advancing APRN practice, particularly CNS practice, but also demonstrating that a CNS can develop an across the continuum program where you're utilizing the strengths of RNs and RDs as well.
So thank you so much for sharing that, Linda. You know what? I'm going to follow up with you because I don't know if you saw the blog where we featured Toby and Marcus, but I think it would be really good for the Campaign for Action to do a blog on your work. So I'm going to follow up with you about that, okay? She's muted. So so Sandra Cotton, I see your hand, and Jean Ann Davison, I do want to come back to you, but we have Clea Luckner back, and Clea and I have been emailing on and off. So for those of you who don't know Clea is an AARP member, is a retired nurse, and also an attorney. And she pointed out the Incident 2 issue in the email exchange is that the quality indicators being monitored and results need to be broadcasted in terms of quality reports. And that's hard to get in Incident 2 billing. And she said that this is a very important part of the story and becomes very important in defense in terms of, I guess, legal actions, also for funding and to pursue physician collaboration. This is part of her issues, and it's her concerns as a as an attorney. So, Clea, did I represent your concerns? Okay.
Yes.
Oh, and you're on. You're on. You're not muted. Speak
I
up.
think I hit it. I found a button to hit.
Okay, great.
No, you
Can you hear me? I'm sorry.
Pat, hold on just a minute, Pat. So,
Early, no
Clea,
problem.
any other follow-up points you would like to make there?
No, you captured it very well.
Okay, great. Thank you. Pat Polanski, fellow director at the Campaign for Action CCNA, your thoughts?
I have so many thoughts. It's kind of overwhelming. Thank you both for really outstanding presentations, but just a couple of things to share. And one from experience, many years at the Board of Nursing in New Jersey, and then in policy arenas in the last, 10 or 15 years. I think a lot like the Sinai examples, that this is such an extraordinary time. And I would just say for everyone who's on the phone, I think there's a way to approach just about anyone. So this could be people in your clinic, it could be people in academia, it could be people in your state, it could be people in a committee. To use generic terms for right now to get to the promised land that we were given such great examples. And that is to say nurse providers perform and are capable of excellent clinical care in every arena or all the arenas. So whether you're talking about diabetes or you're talking about oncology or whatever you're talking about, and then let them find out, are we talking about a CNS? Are we talking about an RN at the bedside, frankly? Are we talking about master's prepared people? Are we talking about APRNs? I think it's a moment in time when COVID has showed the world what we can do and how broad our practice truly is. And I think we need to change our language a little bit away from scope of practice per se. That's where you want to go, but you have to hammer home to organizations and entities and providers now that we are there, we did it. Here's an example of Sinai. Here's what's going on at this place, the other place. Here's what's going on in a clinic with diabetes. And lead in a more generic way, but with the end point that scope of practice needs to change for AIDS, for LPNs, for RNs, and for APRNs, and CNSs, and everybody all the way up.
Yeah.
That's just what I've been thinking the entire time. And I think nationally we have to do that. But I think those of you out there need to think that way. We're more empowered. Now. And there's data to show it.
Great. Thank you, Pat. So Clea, before that, I want to go back to Jean Ann Davison because she's added to what she said about North Carolina and then turned on her camera. So I'm assuming she wants to add on. Go ahead, Jean Ann.
Thank you. Hi. I'm a family nurse practitioner, and I practice and teach both at the School of Nursing at UNC and the School of Public Health. And at the School of Public Health, we have a program for public health nurses, and we have 100 counties in North Carolina, and so almost every county has a local public health department. But we give them extra training to be able to do an advanced health assessment, and also to be able to do STD screening with, and they function with standing orders in the breast and cervical cancer program and the STD programs in the health departments. But for them to be able to do that, they go through the training, and then they have a practicum with another provider, and then they kind of get checked off that they in fact can do this role. But it really helps all the communities, to be able to offer breast and cervical cancer screening and STD screening. And but in North Carolina, we're still behind the 8 ball as far as for advanced practice RNs, for those of us being able to practice to our full scope of practice. But we're hopeful.
I testified there last week.
Yeah, thank you.
You're welcome.
So we're still hopeful.
Yep. It's a good committee. So thank you so much, Jean Ann. I might be following up with you as well. So Sandra, keep your hand up. I will come to you. I just wanted to give the floor to Clea for a minute to see if she had something to wrap up with.
I would like to add to the discussion that as we are looking at how do we communicate the results of this phenomenal thing called the growth of nursing, we need to learn to speak in language that the public needs to hear. And although this is not going to make sense to some of you, but I am by training a nurse midwife. And one of the most effective ways to get patients to follow prenatal care is to show them what the baby looks like before good prenatal care and after prenatal care. Pictures say a lot of things. So it's to show the relationship of what nursing has done with this, whether you call it advanced practice or scope of practice, the role of the professional nurse. And one of those things, the groups I'm thinking about are several groups. One, of course, is the layperson, so they understand what nursing is all about, and they can ask for that. But also the medical profession, they need to tie their hands with something, results. I mean, we have a lot of different results in obstetrics, from cesarean section rate to induction rate, and those kind of things, infertility. We need to pick things that will be important to them. Are there less post-op infections? Are there less maluse of medications? The things that we should be measuring are based on the target group we're talking. Now, that is a non-statistical approach. I am by nature very well educated, but I don't think like that. I want to think about telling the story and, having done a lot of different things, but I don't want somebody who's going to look at and collect data on temperatures and standard deviation of this and all that. We want something that's important. What makes the difference to the doc? Yes, to have patients. Are they getting less calls at nighttime? Those things in their language, what makes it? Because I want them to be able to grab their arms around us as nurses and say, holy shit, look what we're doing now because of the nurses. Good. I can now do this where I couldn't do that.
Right.
That's what my suggestion is. Sorry if I got so excited, but
good.
I'm a midwife, I'm into birthing.
You tell it like it is.
Yeah.
So I really love the idea of the visual too. Really great idea. So Sandra Cotton, I believe you have the last word, the last question, unless somebody else will have a quick one after you, and then we'll wrap up.
Well, I just wanted to appreciate the discussion about the clinical nurse specialist role. It's interesting. I feel like we've come full circle, and I also want to say Clea for president. back in the 80s, so I'll date myself, only my hairdresser knows for sure, is that back in the 80s, Clin Specs were a dime a dozen at Johns Hopkins. And they were the first ones to go when cost-cutting measures came into practice.
Yeah.
We had clinical nurse specialists, even before I came to Johns Hopkins, in rural West Virginia, we had a clinical nurse specialist who was the education specialist between all the critical care units. It is so ironic that I have a student now who is looking at what nurses in the critical care units are learning when they're coming into their orientations, and the lack of a nurse residency program, and wondering, gosh, wouldn't there be a wonderful role for a nurse, as an educator for these units? And I said, there is such an animal, and it's called a clinical nurse specialist, and we need more of them. And it's just the irony of this, that we slaughtered off practically these poor people who were doing such an incredible job. And now people are realizing the role, like APRNs, no matter what role you have, if you're an educator, researcher, clinician, change agent, whatever, you can't be everything to everybody. So I look at these clinical nurse specialists and I say, that is such an incredibly valuable role. And if we got to figure out how to, show me the data, show me the money, we got to figure out how to bill for them. Somebody please do it so we can have them back in the game, because we just need you. It's so true. So I just wanted to say that piece about you.
Thank you. Thank you, Sandra. Lisa Summers, who works on a program and is catching up on the theme of CLIA for President, is pointing out that another important aspect is to support the growing number of nurses and midwives running for elected office, particularly at the state level where most of the work is done. And Lisa, we'll bring you back. How about if we bring you back later this year? You presented for us about 2 years ago, maybe even 3 years ago, before COVID, on that, and we would love to bring you back, okay, for later this year. So great. So speaking of later this year, in one more month, our next Access to Care Learning Collaborative, you lucky devils get to have a conversation led by Peter Reinecke. I will be heading back from the West Coast that day, so I will not be facilitating the call. And in addition to the benefit of having Peter, you will also have the benefit of talking about 3 states where there seems to be some really positive action. So Marcus, you might need to update your map for 2 more states. So Wisconsin had some improvements recently in a bill that passed 2 weeks ago. And I think that there still might be some ironing out going on there. However, Kansas, on Friday, just this past Friday, the legislature, by quite a large margin, passed a full practice authority bill. And it's not just any full practice authority bill. It's 3 of the 4, the CRNAs did not need to be included in it. I think they were already somewhat full practice in the state. But it's the other 3, and it is purely full practice authority. There's no transition to practice. We have not seen that since 2010, when North Dakota passed their law. So now, but the bugaboo is we need the governor to sign it. Well, or at least we need the governor not to veto it. So so hopefully there will be no veto of that bill. But that is a huge bill that passed. And then today, our Georgia friends are unable to join this call because there are hearings going on regarding a signature authority bill in Georgia. And even before that, they finally got their win. Andrea, you will know this. They finally got their win on data. So that is something that that was, so data is, you'll hear next month about why the data bill was so important that Georgia won on. And so Linda Thurby Hay is saying, so why was Kansas successful? Well, you're going to have to tune in next month to have that conversation with Mr. Peter Reinecke. So, and you'll have that conversation with about Kansas, Wisconsin, and Georgia. And Nicole Lavanos from NCSBN is saying, let's go Kansas. And indeed, let's go Kansas. So, listen, Marcus and Toby, wow, what a pleasure to have you here today. Thank you so much. I mean, I learned more from you. Thank you so much for all that you do. Keep the excellent work going. Marcus, keep us posted about your progress in your PhD program. Would love to have you back on for whatever your next is in life. And Toby, I will be keeping you in mind for future advancements too. So
I'm doing children and families and adolescent suicidality as my focus. So my background is community public health and psych mental health nursing.
Good.
Thank you. Thank you for that.
And I'll be practicing my dance moves for you, Wynn.
Thank you. Salsa dancing, here we come. Well, thanks everybody so much. And to all the nurses out there, on behalf of AARP's nearly 38 million members, thank you for all that you do.
Thank you.
Sincerely, thank you.
Thank you. Thank you.
Have a good month.
Yeah.
Take care, everyone.
Thanks, everyone. Bye-bye.
Bye, stay well.
Bye.